clinical care standard on stillbirth. So we're coming to you from the lands of the Turrbal people, and I want to start by acknowledging the traditional custodians of this land and the various lands on which we meet today, and pay my respects to elders past, present and emerging, and to the Aboriginal and Torres Strait Islander people who are here today. So the purpose of this session is to raise awareness about the new stillbirth clinical care standard and to discuss best practice care in the prevention and investigation of stillbirth and bereavement care and support offered to women and families after any perinatal loss. A large number of experts have contributed to the development of this standard. We've brought some of them together today and we're going to be discussing some of the key elements of it. I will introduce our first speaker, but she's not going to come up straight away. Associate Professor Liz Miles is Clinical Director at the Commission on Safety and Quality in Healthcare. She's a general practitioner and she's the chair of the topic working group for this project. And she's going to provide an overview of the clinical care standard and the importance of this work. But before we hear from Liz, it's my privilege to introduce Ashley's story. Ashley is actually sitting here in the room with us today, but we met a week or so ago to discuss the impact of losing a baby to stillbirth.
So my name's Ashley Russo and I'm remembering my first son, my second born, Dominic, who was stillborn at 39 weeks in October of 2014. When we found out that Dominic's heart had stopped, we were given a few different options for what to do next. What my partner and I chose to do was to go home, pack our bags and come straight back into the hospital for an induction that evening. So in the hospital setting, we were given as much time as we wanted to spend with Dominic. We ended up feeling that we would never feel ready to say goodbye. Having to leave the hospital with empty arms is the last thing anyone wants to do when they've gone in to deliver a baby. Going through the death of a baby is shattering in so many ways, in so many different avenues of life. It affects your immediate family, it affects your extended family, and it affects your friendships and relationships outside of that. We had to navigate parenting while grieving, and we had to navigate our daughter's grief as well. And that's been an ongoing thing as she's gotten older, and with our subsequent babies, we've always been very open about Dominic with them, and his name is said daily in our house. It's not an isolated event. It's not a sad day in your life. It's something that you remember every day, whether that's with tears or in loving remembrance.
Thank you, Ashley, for sharing your story. I think it sets the scene really well for why this clinical care standard is so important. So I just would also like to begin by acknowledging the traditional owners of the various lands on which we meet, and pay my respects to elders past, present and emerging, and also to acknowledge any Aboriginal or Torres Strait Islander people who are joining us today. I'd also like to acknowledge women and families who've experienced a stillbirth or perinatal loss, and those who may be in the audience today. We recognise the tragedy of every perinatal loss, regardless of the nature of the loss or the gestational age at which the loss occurs. So stillbirth is the most common form of perinatal death in Australia, with 6 babies stillborn every day. For those who experience it, it is a tragic and profound experience. Worldwide, stillbirth is recognised as a serious public health problem due to the significant and far-reaching impacts the death can have on families and societies more broadly. We understand that, unfortunately, there are disparities in stillbirth rates in Australia. We can see that the rate for all women is 7 stillbirths for every 1,000 births, but for Aboriginal and Torres Strait Islander women, it's 11 stillbirths for every 1,000 births, and for those who are in remote areas, we're talking about 12 stillbirths for every 1,000 births. And this speaks to the need to optimise care for all women and improving access to high quality and culturally safe care, key focuses of the development of the clinical care standard. Sadly, not every stillbirth can be prevented. However, evidence indicates that by providing optimal, high-quality care, we can reduce stillbirth rates, and this is the primary goal of the Stillbirth Clinical Care Standard. The National Stillbirth Action and Implementation Plan included an action to develop a clinical care standard to improve national consistency in best practice care for stillbirth prevention and bereavement care. There have been 26 professional organisations who've endorsed the standard, and this reflects the importance of this work. So the clinical care standard includes 10 quality statements that describe key components of care that should be offered to women and parents. The standard explains what each statement means for women and parents, also for clinicians and for healthcare services. The overarching aim of the clinical care standard is to reduce the number of women who are experiencing stillbirth, especially after 28 weeks gestation, reduce the variation in the approach to stillbirth prevention and investigations after stillbirth, and to support best practice in bereavement care following any perinatal loss, regardless of the reasons gestational age at which it occurs. So I'm going to talk about the 10 quality statements as they cover the patient journey in 3 sections. So the first 6 quality statements focus on ways to improve the likelihood of giving birth to a healthy live-born baby. So risk assessment should begin wherever possible before pregnancy in quality statement 1, and assessment and management of stillbirth risks is also vital during pregnancy as addressed in quality statement 2. Quality statement 3 highlights key risk reduction strategies and aligns with the 3 key elements from the Safer Baby Bundle, including smoking cessation, awareness of fetal movements and safe sleep positions. Quality statement 4 focuses on offering women access to high-quality ultrasound during pregnancy and how ultrasound imaging can assist with identifying stillbirth risks. It's important that all women have access to high-quality ultrasound and that services support them to have this access. Quality statement 5 addresses the importance of responding to women's concerns about changes in fetal movements. And we need to ensure that we have pathways in place to facilitate timely and appropriate assessment for women with concerns. Considerations relating to the timing of birth are addressed as part of Quality Statement 6, with a particular emphasis on supporting informed decision-making. So Quality Statements 7 and 8 address the approach to discussing clinical investigations after stillbirth. Firstly, supporting families to make informed decisions about available investigations. Secondly, ensuring investigation results are documented and communicated appropriately to families, and that we close the loop on any clinical review processes that occur after a stillbirth. The last 2 quality statements focus on providing compassionate, respectful and culturally safe bereavement care to parents after any perinatal loss, and considerations relating to a woman's care during a subsequent pregnancy. Importantly, please note that advice relating to the provision of culturally safe and equitable care has been incorporated throughout the clinical care standard. To support the release of the clinical care standard, a number of additional resources have been developed, including information for women and parents, information for clinicians, and information for healthcare services. All of these materials are available for download from the Commission website. Every stillbirth is a tragedy, and every stillbirth prevented matters. So by shining a light on stillbirth and discussing ways to improve care, we can achieve better outcomes for women and their families. So in closing, I'd encourage you to visit the Commission website to download the clinical care standard and its supporting resources and hopefully incorporate them into your practice. It's now my pleasure to introduce the continuation of Ashley's story as she describes aspects of care that were most valuable to her and why having a standard to support care for women and their families in this space is so important.
During my pregnancy, I was cared for at a group practice where there were 5 or 6 obstetricians. So through the pregnancy, I got to know each of them quite well. So I was always speaking with someone who I already knew. And I found that was really helpful. I meet a lot of families who really struggle with that question of whether things could have turned out differently if someone had involved them in the decision-making process. But for me personally, I find it's one of the things that has helped with my healing the most, knowing we did what we all believed was the best at the time. So we didn't consent to an autopsy, but there were investigations done on his placenta. The diagnostic tests that were done on the placenta did lead to new information about the cause of Dominic's condition, and that allowed us to prevent the same thing from arising in a future pregnancy. One thing that was really notable to me when I went through the delivery of Dominic was that I was treated exactly the same way I was treated when I had my firstborn through the hospital. My favourite thing that someone in the hospital did was I had one of the midwives on the ward come in to check on me, but before she came over to me, she stopped to look at Dominic. And she commented on how beautiful he was. She commented on the name we'd chosen for him. And she did what I guess all midwives in the hospital would do. She, cooed over my little baby before she came over to see how I was going. And I really, really appreciated that way. I was not treated as a patient who'd had a terrible outcome. I was treated as a mum. The hospital staff were really wonderful to us. They gave us opportunities for memory making with Dominic. They took his handprints. They made sure we had a lock of hair. They gave us the opportunity to dress him and bathe him. They made sure that we had the blanket that he was wrapped in at birth. We had all his hospital tags and everything found their way back to us as mementos. There are many reasons why it's important to have these conversations as a community, but also during an expectant pregnancy. Firstly, if women aren't aware of the risks and aren't aware of what they could be doing to prevent a stillbirth or to prevent any kind of undesirable outcome, then if they do sadly find themselves in that position, they're going to be left wondering what they could have done differently, and they're going to hold a lot of guilt around what's happened. It's important to have a standard approach to how to treat families who are identified as at risk of stillbirth and in treating families once they've experienced a stillbirth. Sadly, I still meet families all the time through my work who have really differing experiences of how they were treated before, during, and after a stillbirth. And a lot of the time that can lead to really complex issues in their grief. My hope is that these standards will help to ensure that everyone is treated with the same respect that I was treated with and given the best chance of not only bringing home a live baby, but if they sadly don't, then receiving the best support in that time afterwards.
Thank you again so much to Ashley for sharing her story. I wish we could have shown you more of it, but what we're really hearing there is the importance of consistency in care. Some people get amazing care, awesome. Some people don't, and that's what these standards are trying to fix. So let's dig in a little bit on some of the key elements that we should be keeping in mind. And I might start with you, Carolyn, because we heard from Ashley about the value of speaking about stillbirth risk when someone's pregnant, and it's the last thing you want to think about when you're pregnant. So how do we empower women during pregnancy to understand the risks that could be sort of facing them, but also talk about prevention? Oh, sorry. Before I just start chucking questions around, I might actually introduce the people who are sitting here. I've met them all already, so I don't know why anyone else needs to know who we are. Well, we've already met Liz, so welcome, Liz. But we're also joined by Professor Adrian Gordon, who's a neonatologist at the Royal Prince Alfred Hospital, clinical professor at the University of Sydney, and chief investigator in the stillbirth CRE. Professor Carolyn Homer AO, co-program director of maternal, child and adolescent health at the Burnet Institute and president of the Perinatal Society of Australia and New Zealand. Professor David Elwood, who's Professor of Obstetrics and Gynecology at Griffith University, Director of Maternal Fetal Medicine at Gold Coast University Hospital and co-director of the Stillbirth CRE. And Ms Dina Butler, Senior Advisor, Indigenous Research and Chair of the National Stillbirth Indigenous Advisory Group at the Stillbirth CRE. So a formidable panel of people bursting with knowledge, and we're going to release some of it now. So yes, Carolyn, let's talk about conversations to have during pregnancy.
Thanks, Tegan. And firstly, a huge congratulations and thank you to the Commission for Safety and Quality in Healthcare for the work in developing these standards. I think they're really important. This is a kind of a watershed moment for us in Australian maternity services. For the first time, it brings it all together. And before I answer your question, one of the really important things is that it's written in a really accessible way for women and families, for clinicians and for health services. And so they all have a slightly different angle and slightly different terminology, but I think we can really use them in our practice every day. So coming to the risk conversation, it is a really tricky conversation, and many of us over the years have avoided using the word stillbirth. We've avoided talking about the hard things. And women have said to us, that's not helpful. And we don't want that anymore. We want you to be upfront and tell us stuff. So I think that all midwives, all obstetricians, all general practitioners need to be open and honest and have these conversations in really accessible ways, but not scare everybody, because pregnancy is precious and lovely and gorgeous for the most part. And we don't want women to have the whole of their pregnancy feeling terrified. So there is a real balance. And I think one of the things which I know we'll come back to, Tegan, is having continuity of care, so that you don't, as a provider, have to tell women everything on the first time you see them or everything when you see them, because you might not see them again. If you know you're going to see a family over time, you can titrate the information that's right for that moment, and you don't have to do the big dump at the beginning. But I know we'll come back to that.
Yeah. So Liz, as practitioners, how do you have those conversations?
Thanks, Tegan. So I think, well, as a GP, we hopefully get the opportunity to speak to women before they get pregnant. And that's an opportunity where we can talk about minimising their risks of a range of things, whether it's miscarriage, preterm birth, trying to get pregnant in the first place. And I think stillbirth falls into that. And so I think part of it is actually raising it as an issue. As Caroline says, that we actually don't shy away from it. It is a risk. It's a small risk, but it is a risk. And I think it's a risk that women would like to be able to address. So I think, having the data helps. Knowing what to say really helps in terms of actually being able to give some practical advice. And then you've just got to encourage people along the way. And as Caroline's already referred to, we can address different aspects of it as the pregnancy progresses.
Adrienne, how is it different? How's the standard different to the Safer Baby Bundle?
So I think the standard is different because it includes all of the great work that is going on, but it does go from pre-pregnancy. It's trying to bring in that primary care. It's also trying to incorporate pregnancy after loss. And I think the guidance for health services in terms of the measurement indicators is also great. So we have those measurement indicators in the Safer Baby Bundle, and that focuses on those 5 elements. But those broader aspects are obviously beyond the Safer Baby Bundle. So I think the wraparound of the standard is what's really important. And so, we're giving information that women and their families can expect to receive across the statements, what should be happening from a clinical point of view, and then what health services should be expected to do. So I think it enhances what is already there in a very accessible way.
And as Liz mentioned before, one of the key parts of the standard is this idea of continuity of care, which is going to look different in different models of care. Carolyn, how do we talk about, why is it so important to talk about continuity of care with stillbirth prevention?
Well, we've got good evidence from midwifery continuity of care around reducing preterm birth, around reducing early stillbirth. So we know there's something in there that works. We've also got really good data now, not from randomised trials, but for Aboriginal and Torres Strait Islander women showing really good benefits around reducing preterm birth. And so there's something going on there around this continuity experience. And whether it's a midwife, an obstetrician, a GP, having someone who you trust and you can pick up the phone and have a chat to. And sometimes I think that's what it is, that, if something's going not quite right, if you had to ring the big hospital and not quite know who to talk to and talk to someone you'd never met before and have to explain all your worries, but if you had a phone number on your card and you could just ring that person and have a quick chat and feel reassured and feel that it was someone you trusted. So it's also having someone who looks after you along the way, who knows where you were up to last time. So in terms of sort of even measuring baby's growth, measuring the size of the uterus and the baby's growth, that's the same person doing it in the same way. And so they're going to pick up that it's not going up, that it's going down, that it's flat, because they're the same person doing it in the same way. So there's some clinical kind of benefits. And then there's also the reinforcement conversation. So talking about stop smoking is really hard, that you could have a conversation at every visit that was encouraging and supportive because you knew what conversation you'd had before. So it's all those things, I guess, Tegan.
Liz?
Yeah, I was just going to add that I think the other aspect is that, the woman doesn't have to keep repeating her story and going through that trauma again, that, the person that they're speaking to already knows it, already understands it, and has that context for every consultation.
And Dina, that's where cultural safety is paramount.
Absolutely. I totally agree with everything that Carolyn has just mentioned. But, if you're caring and it's an Aboriginal woman at the centre of your care, this cultural safety is huge. A lot of our women don't come into services because they don't actually feel culturally safe. And to be able to have standards that remind clinicians of that is really, really important. There's for best practice, there is great models out there that are starting to really make a difference for Aboriginal communities. But I'm really impressed with the clinical standard, because what that means is, if we haven't got Aboriginal women caring for Aboriginal women in those spaces, that midwives and obstetricians and other clinicians that work in that space are reminded about, doing things the right way.
We want to get on to timing of birth, but before we do that, I think one thing that's really important to kind of talk about is the standard is a gift because it provides continuity and it provides a framework, but it's also something that you're asking people to fit into their workflows that are already really complex and really full. I'm not sure who wants to jump in on this one, but sort of talking about what it takes to implement something like this and what supports are available.
I might start with that one. I think what the clinical care standard does is it provides a roadmap for everyone. So, particularly if you're looking at health service provision, because I think that health services, we can say that you need to have access to a high quality ultrasound at a specific point in time. But if there are geographic barriers, if there are financial barriers, that's a big issue. And so the standard makes it very clear that that's what we should be expecting. And therefore, health services have got, really good ammunition, if you like, to make sure that that gets put in place. And similarly, having pathways that allow women to get a really timely assessment if they think that they've noticed a change in their fetal movement. So it provides that information for health services. It actually gives really high quality resources to clinicians, and it gives you something to give to the women who have want to consider how they can reduce their risk, but also who may have experienced this. So I think it actually makes our jobs easier. It's got everyone on the same page. Hopefully we're not having to have lots of arguments about why we need to do things. It's actually all laid out in a really clear whole package.
So let's talk about timing of birth. That was one of the things we heard about when Liz gave the key points before. David, why is it such an important consideration in relation to stillbirth prevention specifically?
Well, firstly, I'm very pleased to see that timing of birth is prominent. It's there as one of the quality statements. Number 6. It's
into the mic if you can, just make sure you hear.
It's because I think it is very important. When we were designing the Safer Baby Bundle, the fact that we introduced timing of birth as element 5 was different from other bundles of care that have been implemented elsewhere in the world, and it has been very challenging. I'll be talking about timing of birth later on this afternoon, but of course you can prevent all term stillbirths if all babies are born before term. Of course, it's absolutely true, but we know now that there are significant harms involved in being born too early, inappropriately early. So getting timing of birth right and emphasising that really needs to be a shared decision-making process. It needs to begin early in pregnancy. That women who are at increased risk for stillbirth, that discussion needs to take place early in pregnancy. I think referencing back to the discussion you were having earlier about using the word stillbirth. I mean, the time to introduce that word is not at the end of pregnancy. It's guaranteed to terrify everybody. It really needs to be talked about early in pregnancy. So I think that we can get timing of birth right. I think we've been working on developing a lot of different resources for women and for clinicians to encourage the kind of discussion that needs to go on. But it's very challenging. We know from all of the national data that the timing of birth has been creeping forward. Year by year, babies are being born earlier because decisions are being made about earlier and earlier birth, and not all of that is appropriate. On the other hand, there are some women who are at very high risk of stillbirth who are perhaps not being monitored appropriately and are not having the discussions early in pregnancy about the fact that their baby might be better born a bit early. So we've got a lot of work to do yet to get this right.
What does this mean for regional and remote women? Sometimes there isn't a lot of choice around that.
Well, the decision about the actual implementation of a timing of birth decision is not that challenging in terms of whether it's an induction of labour or a caesarean section. It's getting the decision right that's the challenge. It's not one of the aspects of the Safer Baby Bundle for which I think there should be a big difference for women, as long as they've got access to a maternity service. But things like monitoring pregnancy effectively, I think Liz mentioned about access to high quality ultrasound. I mean, of course, there will be differences there across the country in terms of the resources that are provided.
Carolyn, do you have advice to clinicians on how to communicate these complexities around timing of birth? Because it's not a one size fits all.
Yeah, I mean, as David says, it's been a really challenging conversation to have. We've taken, 2 years, 3 years. It's not quite there yet. So, we've engaged hundreds of people in this conversation, and it is a real balance. We have good data now saying babies should stay in as long as possible. And many women don't want to be induced. They don't want their pregnancy to end. And not all induction of labours are easy. And they are an intervention, and it then alters where women can give birth. So many women then can't use a birth centre, they can't have a baby at home. It really changes the landscape. So I think there has to be good reason for intervention, and that's why the conversation early. So I think the pre-pregnancy conversation is really important about ensuring women are in the best shape. That's a pejorative kind of word, but that women understand how to be healthy in pregnancy early on, like before they're pregnant, and then they get good care during their pregnancy and good conversations and good support, because towards the end of pregnancy, some women say they've had enough, and we interpret that as, we'll induce your labour. And, here we are in Queensland where it's really hot in December, and women wandering around being really pregnant in December thinking, get this baby out of here, I've got Christmas coming up. And so it's easy to kind of see how it happens. But support that says, you're doing really well and your baby's growing beautifully and your baby's in the best place for as long as is healthy and safe. And I think really empowering women about the fetal movement conversation, because that's the best kind of measure as we go along. So, giving women as much information and as much support, and air conditioning.
So we talked a lot about pregnancy so far, conversations during pregnancy, but of course this session is about stillbirth. Can we talk about, it's happened, baby's been born, it's a tragic outcome, And one of the things in the standard is about investigations. So maybe trying to get some clarity around what could have happened. Adrian, how do you approach this discussion?
So I think for anybody who has a stillbirth or any form of pregnancy loss, in fact, everybody's first question is, why did this happen? So even if there's a known cause, even for an anomaly, for example, people always want to know why. They want to know if it was anything that they did, and they want to know if it will happen again. And unless you have a clear framework for investigations, you will never be able to answer those questions that every single family is going to ask you and want to know. So I think having that clear framework around investigations is really important. We've had an excellent clinical practice guideline since 2009, but implementing those guidelines into practice in a way that it doesn't matter if you have this death in Cooktown or in Brisbane, and making sure that the families know that they are entitled to have all of these tests considered, no matter where they are. That's the challenge. And so I think what the standard does is it tries to put that back to not just the people having the discussion about the tests, but the families who want to know why, and to the health services. So having that there, I think, is a really important part of the standard. And it doesn't mean that everybody has to have 500 fancy tests. It just means that the testing should be considered by scenario. We should be following those really well-written clinical practice guidelines already. And that shouldn't be something that people don't feel they are involved in the decision for. So, we heard this morning from Kelly around, the other government support around helping families with resources about discussing investigations, including autopsy. Because we still hear, and I'm sure anyone who's in clinical practice in the room, we still hear things like, we know your baby died because the cord was around the neck and you don't need any tests. That stuff still happens, and it shouldn't happen. There is no reason that should happen when there is a standard around what tests should be offered. And it's completely fine for a family to say, I don't want all of those tests. But the conversation around the test is important, because that's one chance to get it right and help that family next time around. Yeah.
Just a reminder that you can ask questions. We're going to be taking questions via the app, whether you're here in person or you're joining us remotely. So please do ask your questions via the app if you'd like, and we've got some time set aside for that at the end. Dina, I'd love to get your thoughts on cultural safety around investigation.
I think the most important thing that's been mentioned is communication, and with Aboriginal women, particularly those that actually have to be transferred from small communities to the major hospitals. Having an advocate is so important. We've got to understand that for some of our women, English is, not their first language. And I think there's some assumptions made by clinicians that when they explain what's happened, that, the Aboriginal woman sitting there understands what's happening. So I think it's really important that we do have, advocates and have a true so that we can actually communicate what's happened the right way. And the other thing I just want to add too is there's things that happen culturally after a baby has passed, where families want to be able to take their babies home. There's some horrific stories that we've heard in the work that we've been doing around babies being held in morgues for, weeks at a time. And all they want to do is take their baby home and be able to have ceremony. So I think, these are the things that clinicians need to really understand, because that's part of our healing.
And we heard about how important that process is for healing when we heard Ashley's story before, of just the tenderness of that care and how important that can be. When we get into the interpretation and reporting of results, David, what do clinicians need to bear in mind?
I'm glad you raised that, because I think that, again, this is a really important part of investigations. Having the difficult conversations about what investigations to do, making sure that women have access to the investigations, that we try and remove the barriers as much as possible, and there's many barriers there. But we need to remember why we're doing the investigations. We're trying to find out what happened. and interpreting the results is critically important. I think that's why it's really important that clinicians are educated in what do the results mean, that they're able to put together the story, that they can explain why this happened. I think that we really need to be treating this as a very specialised part of bereavement care, and I think it's unrealistic that every clinician can become really well trained and educated in having those sorts of conversations. I think women should have access to specialists that really can interpret the investigations for them and provide good advice about the next pregnancy.
How do you weave that into the idea of continuity of care if you've got someone who becomes a specialist in that?
I don't think it needs to get in the way of continuity of care at all. I mean, I'm a maternal fetal medicine specialist, so I deal with very high risk pregnancy. I spend a lot of my time seeing women through pregnancy who are being cared for by somebody else. I mean, they're having continuity of care from a midwife, from an obstetrician, from a GP. So I'm part of the care, but I'm not the primary carer. And again, I think you can do the same thing. I think bereavement care is very specialised. There's lots of people involved in bereavement care. It's not just one person. But I think particularly interpreting results is really important.
Liz, for GPs, a lot of these tests are done in hospitals. So then you get the results. How do you fit into this ecosystem?
Yeah, so I mean, I think that communication from the hospital to the GP is really important, and particularly around any investigation, so that the GP also understands what went on. And it's similar to many other conditions. If a woman or her family comes in and they're still a bit confused, if the GP has a really good understanding because of the communication we've received, we can help to take them through it. And if there are still unanswered questions, then sometimes we act as an advocate, or we will get back to the hospital. We'll try and get answers for them on that basis. So I think the role that we play is supportive. But also, we help them go through their grief and also plan for that next pregnancy. And as well as seeing the woman, we often see other family members, other people who've been affected. Sometimes we see the healthcare providers who've actually been involved in this, and they might come in and see us and talk to us about it as well. So I think, making sure that you include the GP in the loop and try and make the communication as comprehensive as possible is really important for us.
David, did you have something to add?
Just I think one of the most important things to say about, Kim's got a hand up there, but one of the most important things to say about investigations, and this needs to be said really at the very beginning, is that doing a whole lot of investigations doesn't necessarily mean that we will find an answer. I think that needs to be explained at the very beginning. And sometimes the story might unfold over many weeks or months. I mean, it's not a kind of instantaneous, let's do a test and let's find out an answer. And I think that needs to be made very clear at the beginning.
Adrian?
Just wanted to add to that investigations, something that Ashley said in her video was around one of the things she loved was the care that people took as if her baby was alive. And I think for so many aspects of care and support, we need to think more like that as clinicians. If you were investigating somebody for a cancer diagnosis and you went through their tests, you would be calling the GP, you'd be making sure you had some sort of multidisciplinary discussion, you'd be trying to get everything done in a timely manner. And I think one of the things about tests, particularly protocolized tests after a death, is that they get done, and if you haven't got a continuity model in place, they might not get followed up in the way that they should. So I think, that's a really core part as well. If we can think about this, we should be providing the care that we would be doing if there was a timeliness issue in terms of the results. And I think that's a really good way to think about it. And then nobody would do things like forget the GP or forget to call people back in a week when the tests come back. So I think that's a sort of key thing as well.
Caroline?
And just on that as well, the environment in which the information is giving back to parents needs to be really thought through. And I hope we never see what we used to see with women sitting in an antenatal clinic waiting to see whoever they were going to see to give them the results back. That was barbaric and really, I hope, never happens anymore. But, you know, as David says, it's a specialised skill in going through the results. In that environment needs to be safe and supported and culturally safe and linguistically safe. So you might need an interpreter, or you might need, you know, community support members as well. And it shouldn't happen in a busy antenatal clinic, and it shouldn't be a rush, and families shouldn't think it's their only one chance. So you might not be able to do it all today because it's tough, or you don't have everything. And so you could come back tomorrow, you can come back in 3 months, you could come back in 6 months, and it's okay.
Can we talk about bereavement care specifically? Adrian, you've done an integrated model at the RPA. What's most valued by patients in that model that you've developed?
I think what's most valued is not having to retell your story to multiple different people, and the fact that that particular service has a single point of contact, like many pregnancy loss services in many settings, but the family don't need to come in and go and see the geneticist and then see the pathologist and then go and see the midwife and then try and catch up with the fetal medicine person. So they have an opportunity to choose who is at the appointment, to bring who they want, and to ask for which clinicians are there. And I think that's logistically hard to do, but I think that's the core thing that's valued about our service.
Dina, what are some of the key considerations around cultural safety when we're talking about bereavement care?
Well, again, I think it's having the right people having the conversation. I think that's going to be so important. And I'm glad that, you know, Adrian mentioned the environment and where it's done. That's so important as well. And the right people, you know, I think it is a very complex space, and you need the right people to be sincere, compassionate, showing empathy, all of that. And, you know, sometimes our hospitals are just built like big machines, and it's not, you know, the clinician's fault necessarily. It's just the fact that they're so busy doing other things, and now they've got to have a conversation about something like this, and it doesn't come across very well. So I think it's really important that we have dedicated people that can actually do that the right way.
And Liz, once people get discharged from the hospital, often their point of contact is their GP. How is that relationship? What's the best way that relationship can be?
Well, you know, hopefully it's a pre-existing relationship. So, you know, hopefully we've actually seen the woman through the pregnancy as well. So we've been on that journey with them, and that actually helps us a lot in terms of understanding where they're at. And, you know, what their support needs may be. And I think, you know, for any clinician who's involved, being there, being able to listen to the story of what actually happened, and, you know, being, I guess, as much as you can, try and understand what it has meant for that family, and then, you know, trying to support women because it doesn't go away, as we heard from Ashley. This is not something that stops at that point. So, you know, understanding that as you look after this person over the next 5, 10 years, whatever it may be, when they have their next child, you know, we've got that context that, you know, they have had a stillbirth. So I think it's it comes back to what Caroline said before about the continuity of care. I think, you know, wherever we can provide continuity of care, we should aim to do that. Because I think it makes the biggest difference in terms of building a trusting, supportive relationship that allows free discussion of all of the issues that are actually really important to the woman and their family.
And you mentioned subsequent pregnancies, David. That's a specialist area as well.
Yes, and again, I'm very glad that that got a mention there. Standard 10. I mean, we haven't talked much about preconception care, and that's an area that I think we need to invest a lot more in, whether it's preconception for first pregnancy or subsequent pregnancies. But, you know, it's a fact that you know, being in your first pregnancy is a significant risk factor for stillbirth. Most women who have a stillbirth in their first pregnancy will have another pregnancy. They'll have a subsequent pregnancy. So it's a really important part of, in some ways, I think it's an extension of bereavement care. That the management of the next pregnancy, and it's a really difficult balancing act between the emotional needs, the medical needs, the practical needs of care in that pregnancy. So I'm really pleased it's there as part of the standard, and it's an area that we're currently actively researching within the CRE, and looking at what's available around the country. There are lots of different models. I'd have to say it varies from absolutely sort of gold standard models to models where the special needs of these women are really not recognised. And what we want to do is come up with and I don't think again there'll be one size fits all for this. I think there'll be a lot of different aspects of care in the next pregnancy, but I think they're very, very important, both for the health of the woman, for her next baby, for her family. There's just so many things that flow on from that.
Well, as promised, we are going to take some questions from the audience. They've been filtering through. Thank you for submitting them. We've got a question from Jane asking, has remote patient monitoring been considered for very remote and Aboriginal and Torres Strait Islander families to reduce risks further? I'm not sure who wants to jump on that.
I missed the first part of the question. Has
remote patient monitoring being considered?
Remote patient, I'm not quite sure.
Is this like wearables or Jane question answer?
Not being a clinician myself, I'm not really sure. Maybe we'll leave that one. If Jane wants to post a follow-up with a bit more detail, that'd be great. But another question about...
I mean, if I can just say that there is quite a lot of interest in different types of fetal monitoring. I mean, again, it seems, if you look at it from a scientific perspective, if we can monitor the health of a baby continuously and work out when babies are unwell, then it would have to be a good thing. Now, there's lots and lots of technical difficulties with doing this, and also lots and lots of potential for causing unnecessary harm as well. Specifically in relation to women who live remotely, though, it's an interesting question, but I think we're a long way from having the right sort of technology to do this.
There's actually quite a lot of questions coming through about remote and regional communities. Robin's asking Dina how bereavement care model would work in Aboriginal communities and ARCHOs.
I'm glad someone's asked that question. I've been thinking as we're sitting here, and we often talk about, palliative care has a really good place. And we've got some really great palliative care people that work with even in Aboriginal communities. I'd love to see Aboriginal health workers, you think about the workforce that's already out there. We've got, 1,800, I think there is Aboriginal health practitioners across the nation. Wouldn't it be great to, develop something where we could actually train Aboriginal health practitioners to be able to have this conversation out in communities when the women have returned after having, a loss.
And another question about sort of who hurts when we have a stillbirth, and Debbie's saying the panel refers primarily to women, but the experience of her brother-in-law is that he's still traumatised, he's still grieving, he's crying over their daughter. Does the standard help improve bereavement support for both parents, regardless of gender, Liz?
Absolutely. We do say in the standard at the beginning that when we refer to women, we are actually also referring to their families, and we recognise that families are very affected and partners really seriously affected by this. So I think we're not limiting it just to the woman who has given birth, but also to her support people and to her family members, her partner. All of those people are very much involved in the bereavement care part of the standard.
Adrian, you're nodding furiously. Do you have anything to add?
I'm just, yes, I guess I apologise to the person that answered the question if it sounds like we've all been saying women, but as Liz said, there is a clear statement in the introduction to the standard that says what we mean by that, and that obviously stillbirth affects families and societies and their community far beyond the person who's actually had the pregnancy as well. So
I was having a think she's left us, but I'm having a conversation at morning tea with Cassia, who talked to us this morning. And in some ways, her story is a bit unusual that she has two other children who also experienced the loss of the sibling. And we were talking about the impact on them and also how that's going to change as they get older as well. And I guess one of the things I hadn't really considered is the impact on girls who experience the loss of their sibling, and then how that might influence how they feel about their own pregnancies in the future. It's another area ripe for research.
Yeah, I mean, it affects whole communities, doesn't it, Dina?
I was just thinking, it can impact and I guess make intergenerational trauma for Aboriginal and Torres Strait Islander communities even harder because, especially for a parent, we've heard stories that, it's the first time in 20 years they've actually been able to share what they've, experienced, but also feeling a lot of guilt because they didn't know if they treated their children the right way after that. So there's, that parenting that goes on with, more children. So I think we have to consider intergenerational trauma and how that impacts on the social determinants as well.
Carolyn, we haven't had a chance to hear from you for a while, so I might chuck this one at you first and you can pass it on if you don't want to answer it. But Nicola's asking, what should you say to a woman with concerns about fetal movements and what shouldn't you say?
Well, the shouldn't you say is your baby will move less because it's bigger. And, I confess, I probably said that in my practice years ago. I wouldn't say it again. So, and we shouldn't say some babies don't move every now and then, for a day or two, because that's also not true. I think really important to talk to women about getting to know their own baby's movements. And so every baby's movement is different, and we have stopped the counting, get to 10, you can stop counting kind of thing, because there's so much variability and that wasn't predictive enough either. So I think it's about encouraging women to get to know their own baby's movements and get to know when your baby's busy and when your baby's quiet, and spending some time each day, and I know it's hard when everyone's busy, but some time each day really quiet and sitting and getting to know the baby's movement patterns. And if you're worried, to talk to someone, to ring someone up. Don't wait 24 hours. Don't wait for your next antenatal visit. Ring someone up now. And our labour wards, our maternity units are set up now much better than they used to be, with maternity assessment units, with places where women can go that's not the busy labour ward. So the days of have a glass of water and lie down and your baby will move are gone, and the days of saying your baby's move and slow down are also gone. That shouldn't be in our lexicon anymore. It's much more complicated than that, but I think it's that conversation all the way along. It's not at 38 weeks you have this conversation. It's all the way along.
Adrienne?
And I think the other thing that people shouldn't say is just, is your baby moving, and tick it on the handheld patient record, because that still happens commonly as well. So that doesn't qualify whether it's normal for you or it's changed. So I think that's also important. And just also to add, I've always found the whole your baby slows down at the end of pregnancy fascinating, because as a neonatologist, I'm looking after babies in an incubator who would be in the end of their pregnancy. And if they don't move, someone calls you because the baby is sick, So it's exactly the same ex utero as in utero. If the baby is not moving normally, they might not be well, and you need to call someone.
Did you have something to add there, David?
I was going to agree with Caroline, but it's also really important. I think this is changing, that hospitals are really set up well to be. If a woman is worried about her baby's movements, the hospital needs to be welcoming. And let's have a conversation about this. Come in and see us. Reassure you that everything is okay or not, however it may be. But I think we really have moved on from the time, and this used to happen 10, 20 years ago, where, look, we're really busy at the moment. Come and see us tomorrow.
Yeah.
Not good enough. I mean, we now have excellent international and national guidelines on decreased fetal movements. It's part of the Safer Baby Bundle. we really can do a lot better than we used to do.
We're coming up to time, but there's a great question here from Sean. Liz mentioned that the CCS is a pathway. How do we get healthcare workers, particularly obstetricians, to get on the pathway?
Oh, do I know that answer?
Excellent question, Sean.
Look, I think we have got endorsement from from RANZCOG, so that's a really big start. I think, we want to get publicity, obviously. If our hospitals have adopted this and are starting to, look at indicators for measurement, they will be feeding that back to their obstetricians, hopefully, to all of their departments. So it's got to be a bit of a multi-pronged approach, but the number one thing which we have achieved is actually getting everyone on the same page. So we've got them all on the same page. Now we just need to implement it, and we need everyone to come on board with that.
Only a couple of minutes left of the session. I'd love to hear from each of you one brief thing that you really hope that people take away from the standard, but also this conversation in general. We'll start with you, Liz, because you've had the longest to think about it.
Yes, so I think stillbirth is something that we need to talk about. So it's something we need to discuss before pregnancy. It's something we need to be assessing during pregnancy. And the standard, and obviously, when it occurs, we need to really provide the support at the end of pregnancy, but the standard actually gives us that roadmap and the resources to be able to do that.
Dina?
I love the part Liz mentioned this morning, take note. Think about cultural safety in this space. And I really love the fact that we've got consistent messages to be out there now, and that everybody on board, hopefully takes on. The old times are gone, like Carolyn said. Let's start new. David?
I'd like to go back to what I was saying about preconception care. I think it's a really important area that's been relatively untouched. We tend to start pregnancy care once you're pregnant, and there are so many potential benefits for a whole range of adverse pregnancy outcomes. So I'd really like to see us give a lot of thought to how we can actually do that and do it better. And I think it is, it involves primary care as well, but it also involves hospitals stepping up and actually having access to specialist clinics for more complex preconception care. So that's what I'd like to see.
Carolyn?
Continuity of care. So every woman in Australia needs to know her midwife. She might need a doctor too, and she needs better communication with her general practitioner from the hospital to engage all those providers in her care.
Adrian?
I think the equity of access to care, I think, is what hopefully this will go some way towards doing. So I guess, like what I said before, it shouldn't matter if where you are or where you're from or why this has happened, you should have access to the same care and support.
Well, congratulations on the launch of the standard. Please join me in thanking our panellists.